Good morning, my name is Burton, although most of you know me as Abel's mommy. I am also the president of the Colorado chapter of Breath of Hope here in Colorado. So a little background on Abel. He was diagnosed with a congenital diaphragmatic hernia at 17 weeks gestation. He was given a 10% chance of survival at birth. He was born on October 22nd, 2010. He spent 17 weeks in the NICU at Children's Hospital until he was well enough to come home. Basically, he is our drive, our force, our inspiration to start a chapter here in Colorado. I want to thank you guys all for joining us for the 3rd Annual CDH Summit. We're honored to host it here in Colorado this year. And welcome you to the Mile High City. Unfortunately, we have lots of fires going on in this state, so you probably won't be able to enjoy the beautiful Rocky Mountains as you would otherwise. It's kind of smoky out there, so we're hoping for a lot of rain soon. I would also like to welcome the people that are joining us via live feed today online as well. And with that being said, Elizabeth, who's standing over here to my left, when she initiated the Annual CDH Summit, her intention was not only to gather CDH families, but to gain more knowledge about congenital diaphragmatic hernia, treatment and care of CDH children, as well as the latest research and developments in the field of CDH and pulmonary hypertension. With that being said, I'd like to tell you a little bit about our first guest, Dr. Jason Gien. Dr. Gien is an attending neonatologist over at Children's Hospital, Colorado, and he primarily works with CDH babies and children. Excuse me. He treats them through diagnosis, birth treatment in the NICU, and he follows them as well long-term through the special care clinic at Children's Hospital. In addition to that, he's also involved in ongoing research studies, and today he's going to tell us a little bit about those studies and what he's got going on with the research he's doing. If you guys think of any questions, feel free to write them down. He'll be more than glad to answer them at the end. Also, if you're streaming online, there's a box where you can chat or ask a question. Go ahead and submit them there, and we'll get those as well. I'm going to turn it over to Jason now. Dr. Gien.
Well, thanks for the opportunity to take part in this. It's really an honor to be here. It's nice to see some familiar faces again, and then some other faces of people that I haven't met before. So I don't know, just for me, if it's okay, could we just go around the room and people that I'm not familiar with, could we just introduce themselves, kind of where you're from, and we'll get this talk started.
No,
I'm Burton. You were my baby's doctor.
we're the takers. He's doctor.
My name is Eva Schaefer, and I'm from Minnesota. My son was born with congenital diaphragmatic hernia at St. Paul Children's in Minneapolis.
I am Katie Eden. I am a CDH. I was treated in Omaha, Nebraska. I'm here in Phoenix today.
I'm Katie's mother, so I carried a CDH baby, and she was born in Grand Island, Nebraska, and life flighted to Omaha, where she spent the first month of her life, really in Lincoln, Nebraska.
So Steve Gibson was born, Bella, your daughter. Don't let her tell the rest of the story.
My name's Tanya. I'm from Kansas. I'm the mother of an angel.
I'm Elizabeth. I've helped organize Breath of Hope my experience with CDH with my daughter. However, she's not a survivor, but I love seeing the face that you helped save, that his smile is bigger than his face most of the time. Abel and many of these others. So I notice that there are always that families need to go to at least know they're not alone. And it's not about me or anything else. That's why we're starting chapters. We want to work with hospitals and keep funding in those hospitals, in those areas too.
I'm Crystal. I'm the nurse of a CDH baby.
I'm Maggie. I'm the mother of Alicia. She
is a year old today, actually. And she was born in Colorado Springs, where we live. And Dr. Dean actually came down and got her within a few hours of her birth.
Well, thanks everybody. So we're all here because we're very passionate about CDH, and that's really something that I've decided to dedicate my career to. However, unfortunately, it's very difficult to find a cure or effective treatments for CDH in the clinical setting. Inside of the hospital, when caring for babies, some of these therapies, all of these therapies really need to be proven before one can bring them to the hospital and start treating patients, both with drug therapies as well as interventions. Dr. Crumbleham, one of my colleagues, will talk a little bit more tomorrow on fetal interventions and more clinical experimental therapies that are available for CDH. I really wanted to focus on the laboratory today and what the laboratory's brought to my career and understanding for patients with CDH. So what I study in the laboratory is essentially persistent pulmonary hypertension of the newborn, which people who've dealt with and been around CDH know as pulmonary hypertension or PPHN. Essentially what that is after birth an elevation in the pulmonary vascular resistance inside of the lung. The resistance inside of the blood vessel remains high, which really causes the babies to maintain what's called a fetal circulation. And that's partly why CDH is such a big problem for babies. When one is born, one needs to transition from a fetal circulation to a normal baby circulation, and when one doesn't and you maintain a fetal circulation, essentially the babies become quite severely hypoxemic. So when inside of the womb, the oxygen levels are very, very low. When one maintains those in utero oxygen levels after a baby's born, it can be very, very dangerous and life-threatening. So as we know, when babies with CDH have pulmonary hypertension, there's significant morbidity and often mortality associated with that. And it's this condition that really accounts for death in the large majority of babies. I wanted to break it down into the different causes so that you can understand a little bit better what we do in the laboratory in terms of trying to cure and solve some of the mysteries with this disease. So when one looks at the elevated pulmonary vascular resistance, there's really three things that can cause it. So there's increases in vascular tone inside of the blood vessel itself. This is now a blood vessel that wants to constrict more than it should. So the resting tone inside of the blood vessel is much, much higher than what it should be, which causes the pressure to go up. But the two changes that really hit us hard